स्क्रीन नहीं आ रहा है स्क्रीन So hi dear friends, I think now I'm audible and visible to you. I hope the settings are also fine. So sorry for the delay friends, a very good afternoon. So shall we start the session? If you are there and you can hear me and see my picture clearly and the screen as well, guys, please let me know so that we don't waste much time and start the session quickly. Yes? Are we good to go? Anybody from the DocTutorials team, can you hear me? I think there's a lot of lag here. All right, chalo. Dr. Arun has given me the confirmation, so I consider that you people can see me, and we are about to start. So friends, a very good afternoon and hello from everybody at DocTutorials. So I am Dr. Shivani Jain, your ophthalmology mentor at DocTutorials. So friends, welcome to the session. And to begin with, I would like to ask you, how was your exam? How was your exam? So mixed kind of expressions that I got from my students at different platforms. So some are saying the exam was okay, some was like irritated that exam was something out of the world. Some are like it's okay, whatever was the exam, like we are focusing on NEET PG. So I got a very mixed kind of reaction. But definitely what I have understood is that, see, what I'm going to speak to you now is very important. So what I believe is that INI CET exam is not an exam which you can predict, neither you nor us. It's a highly unpredictable exam, guys. If I talk about ophthalmology, we expect image-based questions, and there was no image-based questions here this time. We expect something problem-based, integrated, like again, we didn't have much of that sort of questions. But what I believe is that if you just target those 6 months, this just 1 year of your preparation, you are not going to clear your INI CT. It is your wholesome preparation from the starting of your MBBS, day 1 of your anatomy lecture, what you think in the anatomy class, how you react to the various things which are shown to you, how you correlate each and everything from day 1 of your MBBS, and it goes till the end of your internship, guys. So you should have a correlation of everything, what you observe, how you follow your seniors, whatever is shown in your clinics. So everything creates a short memory in your mind. And if you keep on writing those things in a diary, in a small diary, guys, and you keep on revising, so the short term memory will be created in a long term memory, isn't it? That's what I believe. So each and every question, what I think is, it's not just are you preparing in those 6 months and you can target them. No. Once you know the topic well, when you keep on revising the things, and it goes into your mind that if something is asked from that topic, I am definitely able to answer. So friends, that is how we have to prepare. Okay, so no predictability, lot of uncertainties in INI-CET, but yes, we believe that somebody who has paid attention in all those years of MBBS are definitely going to get good ranks. Okay, not only in this exam, in whatever exam you give in your life, you will definitely be able to clear with good marks. Okay, chalo. So Dr. Arun, it was tough. Okay, a lot of biomolecular and genetics questions were there, right? But in ophthalmology, I'm happy with the questions. They were good questions, and less of integration, less of दिमाग ज़्यादा नहीं लगाना था. So ophthalmology was easy. I felt the questions were good. But yes, one question was there which was very, very, very confusing. Even I have to drain everything. Even I have to put on a lot of efforts to find the correct answer. But still, I'm not sure what they wanted from us. Chalo friends, so let us begin with the topic. Let's not waste much of the time. Let's talk about the first question. So which of the following has the familial association? This is our first one. So friends, I'm not able to write down. So which of the following has a familial association? I think this was the language of the question. Retinoblastoma, primary open angle glaucoma, myopia, and the fourth option, I'm not very sure about that. Was it retinitis pigmentosa, retinopathy of prematurity, or probably some students are saying there was all of the above as the option. So friends, if definitely all of the above was the option, probably, 100% this is the answer. But if the question was like A, B, C, D, A, B, D, A, and certain kind of choices are there, like you have to answer multiple, then answer should be A, B, C, D if retinitis pigmentosa is in the option. Understood? If retinitis pigmentosa is in the option, then definitely this is going to be the answer. My pen is not working somehow. Guys, my pen is not working. You have to give me 1 minute again to sort out with the things, because I'm not able to. पेन ही नहीं चल रहा, इसको स्टॉप करो. So friends, this is the first question, and I was telling you that if the option is all of the above, definitely all of these are the answers, but not retinopathy of prematurity. Okay. Now friends, we have done this lately in the app, and we have discussed various times in the classes as well, that definitely myopia is the one where we have a chance of heritability. There has been found 25 myopic loci where it has been found that there's a mutation in LEPR-EL1 gene. Okay, now if we talk about myopia, especially the high myopes, the pathological myope has been found to be genetically transmitted. Definitely there are so many genetic and environmental factors as well, but yes, it has been found that there is a genetic correlation in myopia. Okay, now friends, when we talk about primary open angle glaucoma, it is a multifactorial disease, definitely. But yes, when we talk about genetics, there are two types of genes, like myocillin or an optineurin gene, that we have discussed in the app as well. So once we have this primary open angle myopia, open angle glaucoma, so it has been found that the first degree relatives of patients with primary open angle glaucoma has an increased risk. So 10% of the risk in siblings is increased, and 4% of the offsprings will also have a chance of getting this. So myocilin is also called as TIGR. This can be again a question. What is TIGR? It is TM induced glucocorticoid response protein gene. Okay. Now please remember, this gene is also associated with the juvenile open angle glaucoma. Alright. Now please remember, this optineurin gene, which has been found to be associated with POAG, is also there for NTG. Okay, normal tension glaucoma. Now another gene which one should know is about the congenital glaucoma, where everybody knows like CYP1B1 gene is associated. Okay friends, so these are some genes which are associated with primary open angle glaucoma. And retinoblastoma, everybody knows that there are almost 7 to 10% of cases where you have a familial inheritance, though the most common type of retinoblastomas are sporadic. But yes, you definitely have an association of this gene mutation, which can be seen in almost 7 to 10% of cases of retinoblastoma. So this familial retinoblastoma means what? It means that you have the first hit there in the cells before the birth of the baby. Okay, so your parents have a family history and you get a chance of retinoblastoma. Okay friends, so this we have done in the app as well, that almost 10% of the retinoblastomas are familial. So RB1 gene is inherited from your affected parent. Okay, so do not get confused between the heritable and non-heritable ones. Heritable can be divided into further familial and sporadic. Both of them are different friends. Okay, so both of them are different, right? So if I go again back with the question says retinoblastoma, yes, this has a familial inheritance. Primary open angle glaucoma we have discussed, myopia we have discussed, and retinitis pigmentosa, again friends, we know that most of the cases of RP are having a sporadic type of inheritance. They are sporadic, they are not familial, but definitely you can have autosomal recessive cases, you can have autosomal dominant cases, and X-linked cases are also there. Okay, so retinitis pigmentosa again can show you familial cases. So retinopathy of prematurity is the odd man out. So if you get such type of question, I think you should be able to answer from that. Okay, so that was an easy question. Okay, if you know the facts, you will be able to answer the question very easily. So this is the second question, a clinical question here friends. So this says the patient presented with incomplete closure of right eye. On examination, there is a weakness of orbicularis oculi, and cornea also has decreased sensations. So I am confused between the next line. It's was the language that what can be the disorder, or were they asking about the organism involved? Guys, what was the next statement? Can you correct it? Were they asking about the disorder or the disease here, or they were asking about the organism? So some students are saying they were asking about the organisms, and some are saying that hypothyroidism was also an option. Hypothyroidism. All right. Okay. So let us consider hypothyroidism also, but still our answer will remain leprosy here. So friends, we have discussed this in our app also, that there are some causes of trophic ulcers where you have paralysis of the seventh nerve. So seventh nerve is the one which supplies your orbicularis oculi, isn't it? Orbicularis oculi is supplied by seventh nerve, and when you have a facial nerve palsy, you can have a lag of ophthalmos. What is lag of ophthalmos? Inability to close the eyelid completely. So friends, when such thing happens, there is an exposure to the cornea, and it may lead to a inferior corneal ulcer, which is called as exposure ulcer. Okay, for the treatment also, we know we can give a lot of tear supplements. We can also do surgical treatment in the form of tarsorrhaphy. So this was about the exposure ulcers. Now guys, we have also discussed in our app earlier that there are so many causes of corneal decrease in corneal sensations, and leprosy is one of them. Okay, so in detail we can talk about the various causes of corneal sensations loss, in which very important are herpetic lesions, a surgical trauma, any kind of intraocular surgery some important medications. So guys, this is an important question. You can also have a cocaine abuse, some kind of aneurysms or cerebrovascular events, tumors which can cause a seventh nerve palsy, and very important is leprosy, which was there in our question. So guys, if I go back to the question, consider the patient has leprosy. He has come to you with a weakness of orbicularis oculi muscle. Because of that, you can have problems in the sensations of the cornea and the closure of the eyelid. Okay, so this can lead to an exposure ulcer. Now I'll just brief you about the ocular features of leprosy. This is again a potential important expected question, friends. Okay, please remember, leprosy can cause many things in eye, the most common of which is a mild grade, a very minimal kind of anterior uveitis. So this is important. Okay, what is the most common ocular manifestation? It is a low grade anterior uveitis. Now the pathognomic lesion in eye is the iris pearls. Okay, what are these iris pearls? So friends, this is basically the histiocytes which are engulfing your dead bacteria, and they look like whitish lesions within the stroma of the iris. So very nice picture we have here of the iris pearls. Okay, we can also have that we've just spoken about. We can have lag of thalamus, reduced in corneal sensations. Not only your seventh nerve but also your fifth nerve will be involved. That is why you have a decrease in corneal sensations. Okay, now what next is, you have a very small pupil. Can you see this? A very small pupil is there, and with that you have a very low grade uveitis, right? Because of that you also have a loss of pattern of iris, so you will see the iris atrophy as well. Now other ulcers which can be seen is interstitial ulcers, avascular keratitis, and the corneal leproma. Other involvement in the form of scleritis can also be seen. Okay, so these are your ocular manifestations in leprosy. Please remember, an expected question. Okay, so that was an easy one, guys. You can relate it with neuroparalytic ulcer, neurotrophic ulcer, seventh nerve palsy, leg of thalamus, and how should you treat it. Okay, so this is your complete question. Now, let's talk about the next question, friends. Again, a very easy one, I would say. So, which triad can be seen in acute congestive glaucoma? I think that was the language of the question. So, they have given you various different triad, and the very, very easy thing is the walked stride. So, we have learned in the app as well, friends, that acute angle closure glaucoma. Later on, if we see a patient who has had a angle closure glaucoma in past, we will be able to see the walked stride. What is that? And we know the mnemonic also, it is PIG. What is PIG? A poor pupillary dilatation, I is iris atrophy, and G is glaucoma flecken. Okay, so this is your walked stride, a very simple question. Now friends, I will just like to tell you one very important thing. Some books mention P to be a non-dilating pupil. Some books mention this P is to be a pigment on endothelium. So your Parsons mention pigments on endothelium is your P of walked stride. But your Khurana and some other books also mention P to be a poorly dilating pupil. Okay, so these are two things which you should know. Now, what is glaucoma flecken? So we have discussed it also. Glaucoma flecken is nothing but an anterior subcapsular type of cataract which can be there because of necrosis of the anterior fibers. When you have a very high pressure, so your anterior fibers of the lens, they undergo necrosis, and because of that you will have a cataract. This is a complicated cataract. So please remember the mnemonic. It's a very, very easy question. Walked stride seen in the past attack of angle closure glaucoma. So guys, I am not confident what is Gaucher's stride. I am not able to find out what this is. But yes, Hutchinson's stride and Virchow's stride are easy. You must be knowing that you have read in pathology. So because of thrombosis, you remember thrombosis? So we have a triad of endothelial dysfunction, hypercoagulability, and stasis, which leads to thrombosis. And about your Hutchinson's stride, that is seen in congenital syphilis. So you have Hutchinson's teeth, you have a sensory neural deafness, and interstitial keratitis in the eye. So this is your typical triad, a Hutchinson's stride. Okay friends, so this one is also easy, I think. You know, you should be able to answer everything here. Now let's talk about the fourth question. So friends, somebody would say this question is very, very simple. Yes, it is. But I am not sure about the language of the question. Was it asking about the primary action of the superior oblique muscle, and the options were this? Can anybody correct me if I'm not framed the question correctly? and somebody is saying that the question was asking you like this. They have given all three actions and these are the options. So let us consider the superior oblique muscle action first of all, okay? So if you remember the mnemonic, so abid, you should be able to answer. Superior oblique is an abductor, it also is an entorter, and it is a depressor of the eye. So intorsion, depression and abduction. Choice number 4 is the best possible answer. Now friends, I would like to tell you something very very important which can be asked in your further examination. There is a difference between a primary action and a pure action. Please remember, an important question. There is a difference between a pure action and a primary action. So when I talk about the primary action, all three actions are there in the option, Dr. MK. So I suppose this is a better kind of framing of the question. All right. I think this is the better type of framing of the question. So let us go with this question. But what I want to tell you is the difference between the primary action and pure action, because this can be again a potential question, friends. Okay, please see. So when you see this chart, you will come to know that muscles can have three type of actions except for medial and lateral rectus. Why? Because medial and lateral rectus are parallel to your globe. Okay, we know that. Now, the primary action of a muscle is seen when the eye is in abducted position. Please see the fact, it is very very important. So primary action is when the superiors and inferiors are in abducted. Okay, when your eye is abducted, so what will happen? Your superior and inferior rectors are in the same line as with the line of sight. So when your eye goes here, the superior and inferior rectors are in the same line. So superior rectus is primarily becoming an elevator, inferior rectus is primarily becoming a depressor. Please remember the statement, it is important. Now, what next? So what about obliques? So when your eye is abducted, superior oblique and inferior obliques are perpendicular to this line of sight. So that is why they show torsional movement as their primary action. Please understand the reason behind that, okay? So please remember again, torsional movements are the primary action of oblique muscles, and elevation and depression is the primary action when the eye goes in abducted position. A very important fact. Now friends, the next important thing. I have discussed what is the primary action, but what is the pure action? It is a different question. So pure action can be understood when we talk about this question, when I frame the question in this form. So superior oblique is actually primarily a depressor in an adducted eye. So I would say this is a pure action. This is a pure action of superior oblique. Now just let us see this diagram. So you know this is a clinical diagram, friends. You know clinical diagram. So inferior oblique, superior rectus, superior oblique, lateral and medial rectus. Okay. If you remember this diagram, you should be able to tell that superior oblique is a muscle which becomes a pure depressor in an adducted eye. Okay. So this is one fact which I wanted you to understand. Next, maybe they can ask you, what is the pure action of superior oblique? And one option will be given to you will be intorsion. But intorsion is not the pure action. Okay, intorsion, if you see, intorsion is also a function of superior rectus. So how can that be a pure action? There is a difference between a pure action and a primary action. Okay friends, I hope this question is clear to you. So this was a simple one. Now let's talk about one more clinical question, an important one. So a young female presented with blurred vision since a day. Her ocular examination was normal except the pupillary reactions were not normal. They showed a RAPD. So which investigation would you choose the next? So friends, first of all, was this the question and this was the language of the question? Were these the options, or you want to add upon something as the options, friends? Dr. MK, yes, was these the options? Now friends, if this was the question, this is a straightforward question and we are talking about optic neuritis as our differential diagnosis, isn't it? Optic neuritis, we have a young female, blurring of vision, pupillary reactions, RAPD. So I am going first of all keeping optic neuritis as my differential diagnosis. Now friends, optic neuritis, अच्छा medicine lover, okay, I'll do that. ठीक है? We'll also discuss the video in English. Definitely we'll do that. Okay. तो क्या होता है, आई एम कीपिंग दिस ऑप्टिक न्यूराइटिस एज माई फर्स्ट डिफरेंशियल डायग्नोसिस, राइट फ्रेंड्स. सो व्हाट इज हैपनिंग? Optic neuritis, we know that most common cause is multiple sclerosis. You can also have Devick's disease, which is known as Neuromyelitis optica. So friends, please read Neuromyelitis optica from medicine as well, because you must be able to differentiate the clinical, whether it is purely a case of multiple sclerosis or this is a variant. Okay, so lately you have some kind of change in terminology. Now earlier we used to call it Devick's disease, but now it is called as Neuromyelitis optica spectrum disorder. So NMOSD, it has been considered different from multiple sclerosis. Now I'll just will talk about the difference between optic neuritis manifestations in Neuromyelitis optica and multiple sclerosis. Both of them can cause optic neuritis. Okay, both of them, दोनों से ही optic neuritis होता है. but अगर न्यूरोमाइलाइटिस ऑप्टिका से ऑप्टिक न्यूराइटिस होता है, सो व्हाट इज द डिफरेंस? सो फ्रेंड्स, फर्स्ट ऑफ ऑल, इफ ऑप्टिक न्यूराइटिस इज सीन विद डेविक्स डिजीज और न्यूरोमाइलाइटिस ऑप्टिका, इट इज मोर सिवियर, more extensive, more likely to be bilateral. Please remember, generally we get optic neuritis as a unilateral case, isn't it? Unilateral. But if it has to be neuromyelitis optica, you may get bilateral cases as well. Please remember. Okay, so less likely to recover than optic neuritis seen with multiple sclerosis. And please remember the role of NMO IgE blood test. Okay, so most of them, 70% of the patients can have a positive antibody result with that. Okay, so these are the differences. Again, a expected potential MCQ. So friends, if I just talk briefly about optic neuritis, it is purely an inflammation of the optic nerve. It can be divided into papillitis, retrobulbar neuritis and neuroretinitis. So we have discussed in the app as well, when you want to confirm the diagnosis, you must do a MRI. Okay, so friends, if this is the language of the question, if this answer should be the best one. But if they ask you what all investigations are required, if the question was this, like what all investigations are required, so I would say definitely for a patient you would be doing a MRI. Okay, you should do a blood sugar levels as well, though diabetes is not going to cause this, but for knowing the general well-being of the patient, you should get a blood sugar levels also done. Now if I talk about NMO antibodies, yes guys, this is also one of my differential diagnosis, so I would be doing this antibody test as well. Now what about thyroid function test, friends? Thyroid function test. So guys, though thyroid can also cause a optic nerve compression which leads to this kind of presentation, but I would say if the patient has thyroid, he will just not present with only this. He will also have some other manifestations like proptosis, lead retraction and some other features of thyroid. So I'm not considering thyroid here at all. Okay, so thyroid I'm not considering. Please remember, that is how you have to go about for the particular question. Alright, so again an easy one, you can easily answer this question. Now here comes the tough question. So this is punched out lesion in fundus are seen in all except. Now first of all, some students are confused whether it is in all except or they were asking you about punch out lesion is seen in. So can anybody correct me? Was this the question or except was not there in the choice? So straightforward guys, if except was not there, the answer should be toxoplasmosis. If except is not there, because this is by and large one of the most common causes of punched out lesion that we have discussed in our app also, friends, that we have a macular scar, the punched out lesion seen in toxoplasmosis. We have read that very well. Okay, so macular scar, a lesion of congenital toxoplasmosis is the most common cause of punched out lesion in the chorioretinal area. So was this the particular question, friends? Okay, let us consider this question to be this. Punched out lesion in retina are seen in all except. So I have done a lot of reading as well. So let us ask. Okay, so let us just consider this question. Now friends, first of all, what do you understand by punched out lesion? So punched out lesion is an area, a sharp delineated area in the chorioretinal area where you have loss of photoreceptors. Okay, retina has undergone thinning. So please understand, any kind of chorioretinitis, or any kind of retinal dystrophy where you have a RPE degeneration or even ARMD, these can cause a punched out lesion in retina. Understood? Very simple. If you have a degeneration of your RPE, of your photoreceptors, it can lead to a punched out lesion. Why not? So, if I talk about the colobomas, macular colobomas, I'm not talking about optic disc colobomas, the macular colobomas. So this was the article there in your PubMed, and it very nicely has stated that macular colobomas can also have a punched out appearance. Okay, you can cite this article. Macular coloboma, there are case reports that macular colobomas, obviously you have a coloboma, so there will be an area where there is a degeneration of your RB and photoreceptor. So why not? You can have punched out lesions in colobomas as well, isn't it? So in the app we have discussed colobomas, and I've told you that there is a thinning of retina in the region, and yes, you can have such kind of problems. Now guys, when I talk about the question again, so toxoplasmosis can cause such type of lesions. Colobomas can also cause such type of lesion. What about posterior staphyloma? So first of all, coloboma is, posterior staphyloma is what? So guys, this is seen in cases of pathological myopias. When you have a ectasia right there at the posterior pole. Pathological myopes, again friends, I would say there is a chorioretinal thinning. Because the eyeball is big, this is stretching of the choroid and the retina. So obviously you can have RP degeneration. Yes. So pathological myopia may also lead to some special kind of multiple evanescent white dot syndromes. Guys, this was from the app. Please see, I have discussed that young myopic women can lead to a punctate inner chorioretinopathy. This is a difficult and a different type of topic, but I expected questions from this one. That's why we kept in this our app. Okay, so please remember again, myopia, especially pathological myopia, can lead to a chorioretinal atrophy, a degenerated area which may cause a punched out lesion in retina. So I am going with my posterior staphyloma as well. Okay, so posterior staphyloma can also cause a punched out lesion in fundus, though very rare. But yes, if you want to rule out the options, then posterior staphyloma can also lead to a punched out lesion. Okay, now what about the next choices? So some students are saying it was tuberous sclerosis, retinoblastoma and rubella. Let us consider them one by one. So to the best of my knowledge, rubella does not cause a punched out lesion. Okay, I have searched throughout, but what I have found is that rubella, that it causes a salt and pepper type of retinopathy, isn't it? We all know that salt and pepper type of retinopathy is seen in cases of rubella. So this is one very typical picture. You have pigmented areas, you have depigmented areas. Okay, so what will happen if you have salt and pepper type of retinopathy? This is there with rubella. Okay, measles, rubella, but it will not cause punched out lesion. All right, so please consider rubella is the best answer here. Now what about this tuberous sclerosis? So tuberous sclerosis complex is one thing which can lead to punched out lesion. This has been mentioned in the text. Okay, now if I just go with the DDs of all the lesions which lead to the punched out lesions, there will be many. POHS is one, presumed ocular histoplasmosis syndrome, toxoplasmosis that we have discussed, tuberculosis. So all those causes, all those infections which lead to pigmentary degenerated changes can lead to a punched out lesion in retina. Multiple evanescent white dot syndromes is what I just showed you, and any other cause of chorioretinitis can cause such type of lesions in the retina. Okay friends, so this is important, can be asked to you in again some of the questions in your NEET PG exams. Okay, so I consider the best answer for this question to be rubella. Rubella may not lead to a punched out lesion in fundus, but since the question is not asking you except, then you can consider toxoplasmosis to be the answer. Alright friends, now let us consider one question, the last one, which I would say not a core ophthalmology one, but it is a combination of your things in ophtha and your pharma and your medicine. So the question says the 45-year-old male patient presented was started on risperidone. He came with diplopia since morning in the emergency department. On examination, there was an upward tonic deviation of the eyeball. What can be the earliest treatment? So friends, this was the question there in your exam. Now, risperidone is what? It's an atypical antipsychotic agent. So you must remember some kind of ocular side effects of these drugs, okay? So when the patient was given risperidone, he probably had developed this oculogyric crisis, which is also known as acute dystonia. This has happened due to a drug reaction, okay? So what is this dystonic reaction? So you have a prolonged involuntary upward deviation of eye due to a drug reaction, okay? Now please remember, there are certain kind of drugs which can lead to such a condition, and one of them is risperidone, okay? This kind of atypical antipsychotic drug. Now friends, if the patient comes to you with such complaint in the emergency department, the first thing would you do is giving some kind of antidote. So here promethazone would be the best drug to be given, because it is the drug which has the maximum antihistaminic activity with an anticholinergic activity. So first of all, you'll give some kind of antidote. Now, if the question was saying what is the earliest treatment, you can go with promethazine. But if they ask you what else should be done, so some studies says that you can stop risperidone as well, and some says that there is no need to stop the drug, but you can also wait and watch. After some time, the patient will settle down and these side effects will go off, okay? So more Dr. Nilesh will tell you about this when he discusses the pharmacological questions, but what I wanted to discuss with you is this. So friends, if you have a vertical gaze palsy, if you have this vertical gaze palsy again because of side effect of some drugs, please remember barbiturates, carbamazepine and some neuroepileptic drugs can be there, which can lead to a upward gaze palsy. So this can be again an expected questions in your exam. All right. So friends, this was all about your ophthalmology. I hope these questions are clear now. There's no doubt, but the one question which still remains a challenge is about the punched out lesions in retina. Okay, so let's hope we'll get a better clarification of this question, and when I come up with this, I'll just let you know. Okay, so best of luck. Thanks for watching the session, and best of luck from everyone at DocTutorials. Thank you.